Let's talk about basic respiratory function. As a quick review, we have upper airway and lower airway delineated by our larynx. So upper airway, think oropharynx, nasopharynx, ending down there the epiglottis and the larynx. So everything above epiglottis and larynx, we are considering upper airway. So the upper and lower airway delineated by the larynx, and within our larynx, um, we've got what we call the vocal cords, our hyoid bone, very easily broken bone in our body. We've got the epiglottis there, which protects our trachea when we swallow, and then externally we've got our thyroid cartilage and our cricoid ring. So just remember that larynx kind of separates or delineates what we call our upper airway from what we call our lower airway. As we move down into the lower airway, move below the larynx, we've got a continuation of our trachea into our left and right stem, main stem bronchi. Those will branch off into smaller bronchioles, but as we move down the trachea, remember there is that tracheal cartilage, but it doesn't completely encircle our trachea. We have some smooth muscle in there as well. So we've got tracheal cartilage protecting our trachea, but not all the way around. Moving down our trachea is worth noting our carina right there. So as we move down our trachea, we branch off into the right and the left main stem bronchi, and our carina is right there at that fork in the road. And also worth noting, our left and right main stem bronchi, they break off at different angles. Our left angle is much more steep than our right angle. So if we were to pass a tube down here, pass an ET tube down here, or if we were to go a little bit too far, the inclination for that tube would be go into the right side there. So if you go a little too deep when you intubate, probably going to go into right main stem bronchus, and you'll see only right-sided um, chest rise, and we just pull that tube out a little bit, get to above the level of the carina there, and we can inflate both lungs. As we continue down each of the right and left main stem bronchi, each of those, like we said, are going to divide uh, into bronchioles, and those tubes get a little bit smaller, a little bit smaller, a little bit smaller until they end in our alveoli. So in our lungs, for a normal person, got about 500 million individual alveoli. They're ready for gas exchange, ready for circulation around them, and exchanging oxygen, exchanging carbon dioxide. If you were to take all of those alveoli, spread them out onto a sheet, we'd have a surface area of around 70 meters squared, which is huge. So we've got a lot of surface area there, a lot of alveoli ready for gas exchange, which is obviously a good thing. All of this is aided by our pleura. So we've got a visceral pleura and we have a parietal pleura. So our visceral pleura is outside our lungs, but it lines is it's attached to the lungs, kind of lines the outside of the lungs. Our parietal pleura lines the thoracic cavity. So each of these rub against each other when we inhale, exhale. We've got a little bit of rubbing going on. We don't want a whole lot of friction, right? So we need some sort of lubricant, and that's our pleural fluid. So a little bit of lubricant, a little bit of fluid in between those two pleura. Again, the viscera on our lungs and the parietal pleura in our thoracic cavity against the chest wall, you could say. So we've got a little bit of lubrication in between the two. So when we take a breath in and exhale, we've got movement of our chest wall. We've got movement of our lungs inflating and deflating, and that lubricant reduces friction. Moving even further down, we get to our alveoli, and air coming in. So we're ventilating, we've got air coming in. We want gas exchange at the capillary bed. So we've got air coming in, and we've got O2 exchanging with carbon dioxide here in this alveolar space. So we've got pleural fluid on the outside of our lungs when we inhale, exhale. On the inside, we've got what's called surfactant. It kind of helps our alveoli inflate and deflate and not stick together. We've got a little bit of lubricant on the inside of our lungs as well to help this process along. While we're talking ventilation, we'll talk about lung volumes, and really important one is our tidal volume. Typical tidal volume, somewhere around 500 milliliters. This is going to be dependent on your patient's size and their ideal body weight. So we take height into account and kind of take ideal body weight based on their height, and what should their tidal volume be. It's going to differ person to person. If we're bagging just via BVM, we want just a simple chest rise and we'll stop. If we're putting them on a ventilator, we'll want to do a calculation or two, but typically typical tidal volume, 500 milliliters, maybe 400, maybe 600, depending on the size of your patient. We can think of this as the stroke volume. If we're thinking in cardiac terms, we've got stroke volume for our heart with each beat. How much is it? How much blood is it pumping out? It's kind of the stroke volume of our lungs. So for each breath, how much air am I moving? We're also taking into account here a dead space, and in the typical person, dead space is about 150 milliliters. So dead space is air that will move with each breath, but it never goes in, never goes out. It just kind of moves. So dead space is just air that is moving, but we're not using. We've got a few other volumes aside from tidal volume, aside from dead space, to be aware of. So let's go through a few of these here very quickly. Don't commit these to memory, just know they're kind of what they mean and kind of the idea behind them. So first is our inspiratory reserve volume. So if you normally inspire, if you take in a normal breath, you can probably suck in some more air after that. So if you took in a normal breath, and then after that normal breath you forcibly inhaled more air, more volume, that's your inspiratory reserve volume. So that's your lungs saying we can take in a little bit more if needed beyond just our normal. Same thing with our expiratory reserve volume. You take you release your breath, you exhale normally. Well, you can probably push out some more air after that. So whatever that extra air is your expiratory reserve volume. And then our vital capacity. So that's the maximum volume that can be exhaled after a maximum inhalation. So we're taking our inspiratory reserve volume, the air that we have forcibly inhaled after a normal inhalation, and we're taking our expiratory reserve volume, all the air that we could forcibly exhale after a normal exhalation, and then we're adding that to our normal tidal volume. So tidal volume is just our normal breath. Inspiratory reserve volume and expiratory reserve volumes are the forcible inhalation and exhalation, and all of those added together is our vital capacity. So looking at this here, we see our normal tidal volume. These are our normal breaths right here. So I'm just normally inhaling, normally exhaling. The upswing, here's my inhalation, I'm taking in volume, I'm letting out volume. Then we can add on an inspiratory reserve volume here, so I can inhale normally and then forcibly inhale to get myself up here and fill my lungs to this level. And I can, on the way down, I can forcibly exhale and get myself down to here, this volume inside my lungs. And then right here, here's my vital capacity. So I've added this inspiratory reserve volume, added this expiratory reserve volume on top of my tidal volume. So this top line down to right about here is my vital capacity. So you'll notice there's a couple extra things here. There's residual volume and total lung capacity. Total lung capacity kind of self-explanatory. It's everything top to bottom. So if I filled my lungs to their max, where would I be? If I empty them to their max, where would I be? But you notice there's this residual volume right here that is beyond our expiratory reserve volume. And remember, our expiratory reserve volume is I've taken a normal exhalation, I've let a breath out normally, and then I've forcibly exhaled even more to my capacity. You can try that right now. And there's still going to be some left. So our residual volume is any air, all the air remaining in the lungs after a maximum expiration. And that's because we don't want our lungs to collapse on themselves completely. So even though our inspiratory reserve volume takes us to the peak and the very top of our lung capacity, filling them up to the very top, our expiratory reserve volume is never going to get us um, to full empty. There's still going to be a residual volume, and that's just to keep our alveoli open a little bit, to keep our lungs open a little bit so they don't collapse on themselves. Then our total lung capacity, like I said, a little bit self-explanatory. If I were to take that residual volume, add it to everything else, add it to my vital capacity, I've got my total lung capacity. Then we've got this functional residual capacity, which is the air remaining in my lungs at an end of a normal expiration. So I've got my residual volume, and I've got my expiratory reserve volume. So at the end of a normal expiration, this is what should be left over in my lungs. One last conceptual thing for you when we talk about respiratory flow, we think back to Passeur's law and thinking about as we increase the diameter or the radius of a tube, we can get more and more flow, a fourfold effect on that flow. So that applies to both IV catheters and our bronchi and our bronchioles. So as we increase the diameter, increase the size of our um, bronchi and bronchioles, we can get more and more flow. And here, instead of talking about fluid going through an IV catheter, we're talking about airflow through our bronchi, through our bronchioles. With this, we're going to need surfactant to keep our alveoli open. Think back to the visual of that alveoli, or of those alveoli. We've got the surfactant on the inside. That's kind of our lubricant on the inside. Helps with our secretions. And trying to kind of expectorate if we need to cough and get things out. Helps with tissue elasticity, so keeps our alveoli, helps keep our alveoli open, helps keep them pliable and recruited to take the air that we're moving in and out. So that's on the interior. On the exterior, we've got those pleural layers, both the visceral and parietal pleura. We've got that pleural fluid in between. So we've got lubrication on the inside, helping things kind of stretch and remain pliable. And then on the exterior of our lungs, we've got that pleural fluid helping keep that pliable. If you have any comments, questions, concerns, or cuss words, please let me know.